Hi, this is Patrick Horne, president of GAP. Thank you to our sponsor, Madrigal, for their support of this podcast. Welcome to GHAPPcast. I am Patrick Horne, nurse practitioner from the University of Florida, and I'm joined here by my colleague, April Morris from the Richmond VA, and we're going to discuss recognizing the severity of MASH. Welcome, April.
Welcome. Thank you. Happy to be here. How are you?
I'm good. How are you doing?
Great. Doing great. Yeah.
Well, let me start off by just asking you, in your clinical practice, how do you identify a patient that you suspect may be at risk for having MAFLD or MASH?
So, of course, blood work is always helpful. Looking at their comorbidities, if they're a person with diabetes, obesity, they're on statins or some sort of, the lipid profile is off, and you put all those things together, blood pressure issues, and, you really want to look at those patients as being people or patients that could definitely advance to MASH, and want to make sure we monitor those patients. What about yourself? What do you do in your clinic? How do you kind of try to determine who we need to kind of work up a little bit more closely?
Yeah, I would say pretty similar to your approach. Certainly those patients who are diabetic, especially if they're poorly controlled diabetics, those with obesity. But I also look at the patients that may not even have those particular risk factors themselves, but definitely get important about family history, because what I find, at least in my practice, is a lot of these patients may have a predisposition for some of those metabolic diseases because of the family history. And so it's not uncommon for me to find that their mother, their father, their siblings, their aunts or uncles may have had all those things: diabetes, hypertension, hyperlipidemia, et cetera. So I don't know if you see that as well.
That's exactly right. I was going to agree with you because, a lot of times the family history, even though they may look great now, if they've had an early, history of early stroke, early heart attack, early diagnosis of diabetes, any of those things. And also, obesity, sometimes we are trained to eat certain ways with our families, and sometimes that does trickle down. And so, yeah, you're exactly right, making sure you get that good family history as well as their, medical history as well. Yeah, it's very helpful.
Yeah, I find too, if I, specifically drill down, because if I ask patients, do you have any family history of heart disease? Not everybody knows what that means. And so I try to really drill down and specify, has anyone ever had a heart attack or a stroke? Have you ever had stents put in their heart, et cetera? And I feel like that sometimes prompts you, oh yeah, my uncle or my grandmother, or,
Yeah, they tend to remember that. They
Right.
tend to remember, because you hear, oh, I don't know with my mom and dad. We don't talk about that, but they remember when they were hospitalized because they've had some kind of event or intervention. So
Yeah.
that's exactly right. And then, kind of watching, with the VA, I work at Richmond VA, and we automatically calculate the FIB-4. And so those are useful tools with the blood work to identify those patients who, as you see those patients on a regular basis, kind of track their FIB-4, look at FibroScan, which we have access to, and when to escalate to a more, sophisticated test like the MRE or even imaging. Ultrasound can be helpful, and kind of get into those, modalities or tools that we can use to kind of help identify those patients, because a lot of times they don't have symptoms. They don't feel like, oh gosh, I have a liver problem. And so you have to make sure we watch those patients. Yeah.
Yeah, and liver enzymes, as are not always the tipping point. Some of them have elevated liver enzymes, some of them do not. And so, basing your concern or your risk or their risk of having MASH just based on liver enzymes is probably not helpful. So I think, to your point, having those metabolic risk factors, family history, et cetera, may be enough to sort of start screening those patients, not necessarily just whether their liver enzymes are elevated or not. I don't know what your thoughts are on that.
That's exactly right, because I've seen, patients with cirrhosis, and their liver enzymes are completely normal. When we used to do biopsy on everybody, and before we realized that we have other modalities we can use, biopsy, their liver enzymes are function completely normal, but then they have and even platelet count can be normal in patients with, advanced fatty liver disease, and their biopsy shows cirrhosis, or cryptogenic cirrhosis, what we used to call it, in a lot of those patients. So you're right. I mean, you can't necessarily go with liver enzymes if they're up or down, because someone with mild liver disease can have very, very high liver enzymes, and people with low, or normal liver enzymes can definitely have advanced fibrosis. So it is something that we don't want to just let that be the only thing to guide, what we're looking at with our patients. Yeah.
Yeah, I completely agree with you. I think we do the same thing. Do Is your go-to your first line sort of assessment of Fib4, or is it FibroScan, or is it a combination of both? Where do you start?
So the good thing about the way our lab is set up is that they automatically, so if they've ever had blood work in our system, their Fib4 has been calculated. So a lot of times when they're referred to us in the our specialty in liver disease, we've already seen that, and the FibroScan is like the next step. We look at the FibroScan and we have it. We have a nurse dedicated to doing FibroScan. So when we have a clinic, she can do it the same day, and it's easier to do. And a lot of time, primary care is pretty good about doing imaging at least, And so we have maybe an ultrasound. We can see if they have echogenic liver, or even steatosis sometimes is mentioned there. That's a good guide to say, okay, something's going on, but FibroScan usually is the first thing that we'll do when it comes to, kind of monitoring or working up that patient. Yeah.
Yeah. Again, I think ours is similar. I mean, I'm at a tertiary care center, so most of our patients that we get referred either have abnormal liver enzymes or have an abnormal imaging study, typically an ultrasound or something. And, it's always done for some other reason, right? But then it's picked up. And so then they'll come to us, and we do have a FibroScan in our office as well. So that's kind of our first go-to. If that's not if that's not available, or for whatever reason we can't get valid readings, we certainly can utilize a Fib4. We also, I'm fortunate I have access to MR elastography, depending on insurance coverage and all that. But you try to, go with the non-invasive markers as much as I can before going to something like a liver biopsy.
Absolutely. Yeah. Biopsy sort of is not, I guess you can consider it the last resort at this point, or something that you really want to wait until sort of after you've kind of gone through the process of calculating, calculations and imaging and all of that. And then it's like, okay, this picture is either adding up or it's not. And then the biopsy would be the next thing to do. But yes, the MRE, we have that available as well, which is definitely more helpful, and to kind of identify those patients that may have advanced disease and sort of making sure. But it all goes back to their comorbidities, honestly, and diabetes is number one. And when it's uncontrolled, or they've had, just terrible control or just non-compliance or whatever, sometimes that can be helpful to kind of get them on track and healthier lifestyle and all of that. But the FibroScan definitely can be helpful, and as well as, if we have to do a liver biopsy. But now even insurance companies don't require biopsy necessarily to start medication therapy, which is nice now that we finally have something that we can actually use. But yeah. So have you been able to identify those patients, and with insurance been able to kind of use some of the newer medication that's now out?
Yeah, I have. It's interesting. It seems like different insurances are requiring different things, for the prior authorization. But yeah, it's definitely, I've been able to get people access to it, which has been, nice. And so far so good. Everything's, been good. And, I think, what is the next question becomes, how do we monitor for response? And, and what's the time of that? And I think we're learning. I don't know what your thoughts are on that, or if you have thoughts on that. But.
Yeah, and I think it is exactly. It's sort of the beginning, or the what do you call I wouldn't say honeymoon phase, but it's the start of trying to figure out, how do we monitor these patients? How do we see a response? How do we get that positive outcome that we want? And I think we're just trying to figure that out, and what's the best way to to identify and to manage and monitor these patients. So. But it's nice to be able to offer something,
Yes.
but also still lifestyle intervention and changes, and really still focusing on that too, making sure they have a healthy lifestyle.
Yeah. The way I always explained it to patients is, therapy is one of three prongs. Diet and exercise are still a big part of that. And in order to be truly successful, you need to really focus on, you need to focus on all three of those aspects, not just one. The medication may do something, but you really need to add in the diet and exercise can't be forgotten about, in order to, for just the medication.
100%. Yep. And we, I think we do pretty well overall to make sure we still talk about diet, to still talk about exercise, still talk about, protein intake, vegetables, and be careful with low carb, it is so important to make sure we remind patients of that, because sometimes those closest to them and sort of the family history is what it is. Sometimes they can be the most sabotaging of them all, when it comes to diet and exercise. So it's great to make sure to remind them to get that support that they need to focus on that, as well as medication therapy. So yeah, I agree.
Do you have any specific diet or exercise recommendations that you guys make as in your clinical practice specifically?
So of course, before we even had options for treatment, we had a metabolic liver clinic,
Okay.
and that's what we did. We had a dietitian on staff, and we really talked about, we didn't put a number on it. We didn't call it ketogenic or any of that, but we really just focused on lowering the carb, intake, increase in protein if it's safe from a renal standpoint and all of that, increase in protein, and then vegetables. I always say vegetables need to be your best friend, and they need to be in your diet. And it really does help with fiber as well, when you're talking about higher protein and lower carb. And so we really do follow that. And it's more in line with the Mediterranean diet.
Mm-hmm.
Do less red meat, but do more fatty fish and different things, but also the fibrous foods, the lentils and, vegetables and all of that. And then exercise, I usually tell them, make sure you get your heart rate up. You don't have to go out and run a marathon and do cartwheels, but you do definitely want to exercise 3 to 4 times a week, 3 to 4 times a week, to make sure they're getting that strength training in as well as aerobic. And so I really try to make it simple and easy and just say, just eat real food. There's no Cheeto tree, no Dorito tree, no, Cheetos. You want to make sure that what you're eating looks like the food that comes from the earth, and that kind of thing, and just make it real simple, that if it doesn't look like food, it shouldn't go in your body, that kind of thing.
I like that. And I the old adage of you shop the outer rim of the grocery store and not the inner aisles where all the boxed and the canned foods are and everything like that. I still use that all the time.
100%. Yep. And it doesn't change. And it's like, this stuff is no magic pill or secret. It's basically just literally eating real food. And I've always said that as well, just making sure that it's real, it's not processed foods. And on the outside of the grocery store is where it is. And it should go bad. It shouldn't last forever on your shelf, that kind of thing. And also the, high sodium foods with some of our advanced liver disease, they need to stay around the perimeter and just really focus on the fresh and produce and different things. So, yep, I agree.
Do you give your patients a specific weight loss goal per se, whether it's percentage or a certain amount, or do you just base it on whatever their starting weight is, or how do you approach that?
So yeah, I really just, to me, it does help knowing that if they're 300 pounds and I tell them that, losing 10% of your body weight can make an improvement, a positive improvement, or can make an impact. That is more realistic for patients to say, oh, well, okay, I can do that, versus you need to lose 100 pounds or 100, you need to lose half your body weight. 10% is usually the go-to, I will say, because we know that can show and has shown improvement in health, especially with liver disease. And so what do you typically recommend? Do you have a certain, I go back. I start with that, and if they do that, great, but let's continue, because you do want to get them down and get out of that obese range if possible. But what's your approach? What's your strategy?
Pretty similar. So I usually say somewhere in the 7 to 10%, ideally closer to the 10%. But like you, a lot of patients, even if they can achieve that 10%, typically they still have they need to lose more than that, but that's a good starting point, and it's usually very attainable. That's depending on the patient, of course. That's somewhere between 20, 25, maybe 30 pounds, which seems like a lot, and it can be in it. But I tell them also, this is not a fast process. This is a slow process, and that's okay. Like, we don't want you to have rapid weight loss. We want you to lose it slowly over time. And so, I think it can be achievable. But again, to your point, I don't want them just not necessarily all the time stop at, say, 10%. I think they need to, most of them continue to go on, but it's a good starting point. And if they reach that, then I think they feel good about it. And then it reinforces to do more.
Right. And then I even start with liquid. I said, stop drinking liquid sugar. Like, stop the
Yeah,
juice,
that's a good
stop the
point.
soda. I said, you are putting liquid sugar in your body and it has no barrier for breakdown. So it goes straight to your blood and blood sugar. And I said, if you can just eliminate liquid sugar, and I do say it that way, but the
Yeah.
juices, the tea, the sweet tea, I'm Southern, and in Virginia, there's a lot of sweet tea going on, and sodas.
Yeah.
That can even make a difference if they can see weight loss with that. And they may not need to change initially their food, but just say, hey, drink more water during the day. They could be helpful too. But you're right. Yeah, they need to see that be motivated and get that drive by seeing that initial 7 to 10%. Yeah.
Yeah, and I think that's a good point, bringing up like the liquids and the drinks, because I think we focus a lot on food, and obviously around fresh vegetables, fresh fruits, the leaner proteins, et cetera, lower carb. But I think we sometimes forget about the liquids. That brings up a good point. And I myself even, need to think more about, not only asking them their sort of dietary history from a food standpoint, but also from a liquid standpoint, and see what are they drinking, because that's a very good point.
A lot of patients are like Red Bull, and I was like, oh my gosh, the sugar involved. Or, any of those. They have great energy drinks without sugar, but a lot of people go to Red Bull tastes so good, and because it's liquid sugar. So sugar is highly addictive, and so we really try to educate on that piece as well. That sugar is a big problem in our country. They put sugar in a lot of things, but liquids or your liquid intake can easily be switched over and can make a big difference as well. So, yeah.
In your practice, do your patients have access to a dietitian that helps them? Or?
We do. Yeah, we've been fortunate that we do have one on staff.
That's great.
Because we're a transplant center, and we are required to have a dietitian. She also works in the metabolic liver clinic. And so she also, and with dietitians, you also have to make sure they understand, the liver patient, when it becomes low sodium, and also diet when it comes to weight loss and fatty liver disease and all of that. And, liver patients are great, but they're complex. And so, yes, but it's good to have a dietitian, someone who kind of lives and breathes, different things and can educate and has more time to spend with the patient sometimes and talk to them and check in with them, on a regular basis to make sure they stay on track. Yeah. Yeah. Do you all have a dietitian or something equivalent?
We do have some at our hospital that I do refer my patients to them when I can. And then I've got some patients I've talked to who live far away, or whatever the case may be, and then they've sought out dietitians in their local area. And so I think but I think to your point, it's important that if your patient is gonna see a dietitian, that they're seeing a dietitian who's well educated and well versed in sort of the liver patient, especially if we're talking about a patient that may or may not have cirrhosis and all the other complications. And it does get complicated because you're talking about a patient who typically has some like diabetes, hyperlipidemia, hypertension. They may have other heart conditions, and so it's not only low sodium, it's it's low sugar, it's X, Y, and Z, and so then you're trying to add in the ability to lose weight, and or patients that are diabetic and are on insulin, and so if you can access a dietitian that is well versed in sort of the complex patient, I think that helps a lot.
Definitely
so I think
helpful.
That's great.
Yeah, for sure. And not all dietitians are made the same, but if you find a good one, and like you said, sometimes even taking time to educate and kind of do a crash course on our patients, it definitely can go a long way to offload some of that work off of you, so you can because MASH patients, there are a lot of them out there. So definitely any kind of assistance and help is definitely will help our patients, but help us as well. So yeah.
How often do you see your patients in the clinic? Say after starting a therapy, like how often are you seeing them back?
So it all depends on the patient. Usually when we start a new medication, especially something that's fairly new on the market, usually a month, 4 to 6 weeks.
Okay.
Like we want to see them back and to say, hey, how you're doing? Especially with the, sometimes GI issues that may come up, diarrhea, different. So a lot of that will come up early on. And so you want to make sure that they don't stop medication. They don't stop and say, I had diarrhea, my stomach, oh my gosh, I had to stop. So you do want to capture and just have that patient come back within a month. 4 to 6 weeks if your schedule allows. Our schedules sometimes be very busy, but I think it is useful to kind of check in with them early on, especially with some of the side effects that may come up. Yeah.
Do you check any labs while like early on in treatment or anything like that?
So it depends. Not necessarily. It really is symptom management. And not. I probably would wait, 2 to 3 months just to see how things are looking, and things kind of settle down a little bit with sort of symptom management, but also give it time, to kind of kick in and work. Unless you're concerned about other things that you want to kind of keep a close eye on, I would probably wait 2 to 3 months before doing blood work in that patient. Yeah. So
I think that kind of wraps it up. So, April, I want to thank you for joining me today, and that will conclude our podcast. Thank you guys for joining.
thank you. Yeah.